Welcome to a new episode of Evidence Echo.
Today, we're plunging into a global health challenge that's, well, it's critical, yet somehow surprisingly overlooked. Just try to imagine this. In Sub-Saharan Africa, something like 93% of people, they just can't get safe, affordable, timely surgical and anesthesia care when they actually need it.
It's a staggering figure, truly.
It really is. And it's not just about, getting to a hospital.
No, absolutely not. It's very much about the quality of care once you're actually there. And our goal really is to pull out the most vital insights, maybe some surprising facts, just to get you well-informed and quickly.
Okay.
We're essentially asking, how can a region facing such huge surgical needs build effective, sustainable health systems, especially when, the foundations can be fragile and the funding gaps? Well, they're vast. Each insight we share should add another piece to this really complex puzzle.
That's a great way to frame it. Because the big picture challenge here is immense. The burden of surgical disease in Sub-Saharan Africa. It's estimated at 38 BNALIs per 1,000 people. And DALIs, for anyone not familiar, disability-adjusted life years. This is basically a measure of healthy life years lost.
Yeah.
It really highlights the devastating impact these conditions have.
And globally, you're looking at over 5 million excess deaths every year just from poor quality healthcare in low and middle income countries.
Wow.
What's truly striking, though, from the sources we looked at is that surgical patients in Africa specifically face mortality rates twice the global average.
Twice.
Yes, twice. And this isn't just about a lack of access. It points to a profound quality deficit. You have patients, often younger, maybe with fewer complicating conditions, facing a significantly higher risk. It really highlights a system that's struggling not just with quantity, but with, fundamental competence and safety.
That certainly underscores the urgency, then, of understanding the system better. And you mentioned the system. Our sources point to district hospitals being right at the heart of it. What exactly is their sort of unique and crucial role there?
Well, district hospitals, as the WHO defines them, they're the first level of healthcare that provides actual inpatient surgery and anesthesia. So they play an absolutely vital role, especially for serving these vast rural populations. And critically, they take some of the immense pressure off the bigger referral hospitals.
Right, freeing them up.
Exactly, allowing those facilities to focus on the more complex tertiary cases.
So they're the front line, really carrying a huge load. What kind of capacity are we talking about? And, the volume of procedures.
It's fascinating, actually, the sheer diversity you see. Our sources show they can range anywhere from, say, a modest 21 beds.
Wow, small.
Yeah, up to a pretty substantial 371 beds.
Okay.
And then in terms of surgical volume, it's incredibly varied. You might see just 239 operations a year in one place. And then up to a surprising 5,233 operations per year in another single district hospital.
That is a massive range. It really shows how adaptable they must be and the varied demands they're facing.
Definitely. It highlights that critical sort of Swiss Army knife role you mentioned.
Yeah. The three most common procedures reported are C-sections, laparotomies, hernia repairs.
Yeah.
But it sounds like it's not just the basics.
Not at all. They also handle a really wide array of orthopedics, plastic surgery, even some neurosurgery, including, complex procedures like hip replacements sometimes.
Hip replacements.
Yeah.
In a district hospital.
Yeah. It really speaks to the incredible scope of work being done, often, as you can imagine, with very limited resources.
Absolutely. But the workforce, you mentioned challenges. Let's get into that because that sounds critical.
It really is. And this is where it gets quite stark. Back in 2010, the estimate was just one surgeon for every 25 million people in rural sub-Saharan Africa.
1 per 25 million. That's hard to even picture.
It's an astonishing ratio.
So given that, who is providing all this care? You mentioned C-sections, laparotomies, even hip replacements.
Well, the sources indicate that for anesthesia, it's often non-physician clinicians.
Okay, like clinical officers or nurse anesthetists.
Exactly. Professionals trained specifically for anesthesia, but not medical doctors. They're mainly delivering general and spinal anesthesia.
And for the surgery itself?
That varies quite a bit depending on the country. You'll find specialist surgeons, yes, but also medical officers and, again, non-physician clinicians.
And the training? Is it sufficient for the range of things they're asked to do?
That's a key question. The data suggests medical officers, for instance, often have quite limited surgical exposure during their training. And there was a specific example from Malawi. While clinical officers perform most C-sections at the district level, which is vital, The concern raised was whether they're sufficiently trained for more complex emergency procedures, like, say, an emergency hysterectomy that might be needed during childbirth.
Right. So you're potentially trading some level of specialized skill for just getting someone there to do the procedure.
That's the tension, yes. Access versus potentially increased risk in complex situations.
It seems clear that this reliance on a very diverse workforce, some maybe with limited specialized training, it must lead to challenges with patient outcomes.
Yeah.
What did the research show about complications?
Yeah, the most common perioperative complication reported, so things happening during or right after surgery, is surgical site infection. That came up repeatedly.
Okay, SSIs.
Exactly. And the leading causes of perioperative deaths mentioned were sepsis, hemorrhage, and complications related to the anesthesia itself. What's also really clear from the sources is that actual research on safety, quality, and even just the volume of care in these specific district hospital settings, it's still pretty scarce.
A knowledge gap.
A significant knowledge gap, yeah.
And that scarcity, that lack of focus on quality, that brings us right to another key insight, doesn't it? It's one thing to provide access to care, but delivering it consistently, high quality, evidence-based,
Yeah.
that's what actually saves lives and reduces disability.
Precisely. You absolutely need that consistent quality to move the needle on mortality and morbidity. But despite that critical need, our sources found fewer than 50 studies.
50 total.
Fewer than 50 specifically focused on improving the quality of surgical and anesthesia care in hospitals across the whole of Sub-Saharan Africa.
That feels incredibly low given the scale of the problem.
It's a very small number, yeah.
Right.
Especially when you think about the profound impact quality has on whether a patient survives surgery or not.
And even within those few studies, the focus seems quite narrow.
Extremely narrow. Nearly 90% zeroed in on the safety aspect of quality. Things like the surgical safety checklist, which is important, or reducing those surgical site infections we mentioned.
Okay, safety makes sense.
It does. And about half also looked at effectiveness. Does the surgery achieve the intended result?
But what's missing then?
Well, here's the crucial insight, I think. Key quality domains like efficiency, how well are resources used, equitability, does everyone have fair access, timeliness of people getting care soon enough, and patient-centeredness, is the care respectful and responsive. These are largely neglected in the research.
So efficiency was only in, about 8% of studies? And equitability even less?
Just 8.2% for efficiency, and a mere 4.1% looked at equitability.
Wow. Why do you think that is? Why are these other critical aspects, things that clearly matter for a functioning system, so overlooked in the research?
That's a tough question. It could be funding priorities, maybe perceived difficulty in measuring these domains, but it's a profound oversight, especially when efficiency directly impacts how many people can be served with limited resources, and equitability is about who gets access in the first place.
Yeah.
And this narrow focus, it's compounded by methodological weaknesses in the studies themselves.
How so?
Well, recognized quality improvement methods like Plando Study Act cycles, PDSA cycles.
Yes, the structured improvement process.
Exactly. That structured way to test changes, they're rarely used. Fewer than 10 of those studies actually employed methods like that, or implementation science approaches.
So we don't even have good data on how to implement changes effectively.
We have limited data, and while things like acceptability, do people like the intervention or adoption, or people using it, get reported, the actual cost of implementing these quality improvements is almost never assessed.
Which makes it impossible to know if they're sustainable or scalable, right?
Precisely. You don't understand the true resource implications.
Okay, so we have workforce constraints, quality gaps, research that's scarce and narrowly focused. With all these challenges on the ground, what are the proposed solutions? What's the path forward look like, according to the sources?
Well, many countries in the region are looking towards national surgical, obstetric, and anesthesia plans. NSOAPs, they're called.
NSOAPs.
These are meant to be critical frameworks, sort of roadmaps to improve access and, importantly, integrate surgical care into the broader national health priorities. Make it part of the main plan, not an afterthought.
That sounds promising. A national strategy. But implementing these plans must cost a fortune.
Yes. And the insight here isn't just that they're expensive, it's that the astronomical costs really expose a deeper systemic challenge.
How do you mean?
Well, these aren't just minor items you can tuck into the budget. They demand a kind of complete reevaluation of how national health spending is prioritized. Just to give you some examples from the reports, Nigeria's NSOAP was estimated at $16.8 billion.
Billion,
yeah. Rwanda's was around $69.7 million. Tanzania's about $597 million.
Okay, still huge sums. How does that compare to their overall health budgets?
That's the key comparison. While sometimes these NSOA POS might look like small fractions of the overall long-term health sector strategic plans, like Nigeria's was only 0.09% of its big multi-year plan. When you compare it to the annual health budget, it's a completely different story. Nigeria's NSOAP cost, that's $16.8 billion, was 349%, almost 3.5 times its entire health budget for 2019.
350%. So basically completely unaffordable within a single year's normal budget.
Exactly. It highlights these immense financing challenges.
Which makes sense because we know globally, government spending is usually the main source for health funding. But in Sub-Saharan Africa, it's different, right?
Very different. Only about a third of all health funding in SSA comes from governments directly. A lot relies on out-of-pocket payments and external aid.
Right.
And many countries in the region are spending less than 6% of their GDP on health. Remember the Abuja Declaration? The African Union pledged to allocate at least 15% of the annual government budget to health.
Yeah, I remember that. Are they meeting it?
None of the countries that have actually costed out their NSOAPs are anywhere close to hitting that 15% target.
So it begs the question then, how on earth are these incredibly ambitious and clearly needed plans supposed to be funded with already strained budgets?
That's the multi-billion-dollar question, isn't it?
Literally.
Literally. The sources do point to some proposed solutions. Nigeria's National Strategic Health Development Plan 2 is often cited as an example. The strategies include things like trying to align health funding better with national priorities, expanding basic healthcare funds with help from donors, and the private sector.
Okay.
Obviously, trying to increase the government budget allocation itself, strengthening public-private partnerships, PPPs.
Right, getting private companies involved.
Yes, where government and private entities collaborate, and also domestic resource mobilization. So finding money internally.
Like taxes.
Exactly, things like taxes on luxury goods, alcohol, cigarettes. Trying to find new revenue streams within the country.
Okay, so there are ideas for funding, even if they're challenging. But even with these big national plans taking shape, children's surgical care.
Yes, that was striking.
I mean, the statistic was something like 85% of children in Sub-Saharan Africa will need some kind of surgical care by the time they're 15.
That's the estimate, yes.
Yeah.
A huge potential need.
But the NSOAPs, these big national plans, they barely mention kids.
It seems so. A review found only about 25%, a quarter of the NSOAPs actually dedicated specific sections to children's surgery.
Only a quarter.
And maybe even more concerning, 12.5%, that's 1 in 8, didn't mention children's surgical needs at all.
Wow.
And even when mentioned, the number of citations or references specifically about children's surgery was minimal compared to general surgical conditions.
That feels like a major disconnect, doesn't it? You have this huge potential burden of disease in children, but the national plans aren't really prioritizing it.
It absolutely highlights a disconnect. And there seems to be very little primary data being reported in these plans about how common specific children's surgical conditions actually are.
So the plans aren't even based on solid data about kids' needs.
It appears not, or at least that data isn't being well integrated or prioritized within the planning documents. It's a significant gap needing urgent attention, especially given how vulnerable children are.
Definitely. And as if that wasn't enough of a challenge, there's another rising tide. Cancer care?
Yes, the burden of cancer globally is growing rapidly, and it's disproportionately hitting low- and middle-income countries.
It's the second leading cause of death worldwide now, right?
That's correct. And in West Africa specifically, the numbers are stark. In 2020 alone, over 247,000 new cancer diagnoses and almost 165,000 deaths.
And you mentioned a ratio. Mortality to incidence.
Yes, the mortality to incidence ratio was 0.67, which basically means for every 100 people diagnosed with cancer in West Africa that year, about 67 died from it.
And how does that compare?
Significantly higher than in high-income countries, where the ratio is closer to 0.47. So your chances of surviving a cancer diagnosis are considerably lower.
And surgery is crucial for cancer treatment, too.
Absolutely vital. For up to 80% of cancer patients, surgery plays a key role, whether for diagnosis, treatment, or palliation. Breast cancer, incidentally, carries the greatest burden among cancers in West Africa.
But delivering that complex cancer surgery must face all the same challenges we've discussed, maybe even amplified.
It certainly does. The challenges echo the broader issues, definitely.
Like funding.
Funding is huge. There's a lack of universal health coverage for cancer in most places. So most patients face crippling out-of-pocket costs.
Which means they probably delay seeking help.
Exactly. Leading to late presentation, often when the cancer is advanced and treatment options are much more limited or less effective.
And the workforce, specialists.
A massive issue. There's a severe shortage of subspecialty trained clinicians, surgical oncologists, medical oncologists, radiation oncologists, pathologists. We found figures like some areas having only one medical oncologist for an entire country.
One oncologist.
Yes. And for surgical subspecialists in West Africa generally, the number was about 0.17 per 100,000 people.
0.17.
Compared to around 7.9 in the UK or maybe 18.5 in the US.
The difference is just vast.
That's incredibly stark. Then there's infrastructure.
The hospitals, the equipment.
Right. Many West African countries don't meet that basic recommendation that 80% of the population should live within, say, 2 hours of a cancer care center.
2 hours.
And a radiation therapy, which is critical for many cancers. Only 18 centers in all of West Africa, out of 262 for the entire continent.
18.
Right.
Right.
And even those facilities that do exist, they struggle constantly. Erratic power supplies, machines breaking down, no maintenance contracts to fix them.
Just keeping the lights on and the machines running is a challenge.
A major, major challenge. And finally, data. Just like with children's surgery, there's a scarcity of good national-level data on cancer. A lot of what we know comes from registries at specific hospitals or maybe regions, but not comprehensive national data.
Which makes it really hard to plan effective national strategies or allocate resources properly.
Precisely. It hinders informed policy decisions across the board.
Okay, so let's try and synthesize this. What does all of this mean for you, our listener, taking all this in? That district hospitals in Sub-Saharan Africa are doing absolutely critical work, handling a huge volume of surgery, but with incredibly limited resources and this very diverse, sometimes undertrained workforce.
That's right. And while these national plans, the NSOAPs, exist and show ambition to improve surgical care, the actual focus on quality improvement within them seems surprisingly narrow. It's mostly safety, not efficiency or equity.
Yeah. And funding remains this enormous barrier, requiring some really innovative and probably difficult solutions.
Absolutely. And crucially, as we saw, specific high-burden areas with huge need like children's surgery and cancer care, they just aren't getting the prioritization or the resources they need within these big overarching strategies.
It feels like there's a mismatch.
There is. The data really underscores this gap between the ambition for better health systems and the immense challenges in capacity, funding, and having a truly targeted focus on the ground.
So we've covered a lot: the frontline hospitals, the quality gaps, the ambitious plans, the funding struggles, the overlooked areas like kids' surgery and cancer. It paints a picture of a profound gap, really, between the recognized burden of surgical disease and the actual capacity, the quality, and the strategic focus needed to tackle it effectively. Which leads us to our final thought for you. What stands out to you most about how these insights, the workforce realities, the quality blind spots, the funding paradoxes, the specific gaps in care, how would all this guide future efforts? How can we strengthen these health systems in a way that genuinely meets the needs of all populations, especially the most vulnerable kids and adults across Sub-Saharan Africa?